Good afternoon, everybody. My name is Jody Rich, and along with Steve Higgins, we're going to be co-chairing this session on emerging research on addiction and overdose. We're going to be helped with Tracy Green and a small army of savant technicians and some wonderful presenters. I just want to point out a couple things before we get started. The first is prior to the COVID pandemic, opioids and overdose epidemic in the US was the worst public health problem in 100 years. And if not for the pandemic, it would certainly have stayed that way. What the impact of the pandemic on this has really been to distract everyone's attention away from it, and also have some detrimental impacts on the overdose and opioid epidemic, such that now we are far worse off than we were a year and a half ago in terms of deaths. And the deaths have continued to rise both with opioids and also with stimulants. And this is a Category 5 hurricane. This is all hands on deck. We really need to stop doing the silly things we've been doing for the last many decades and start focusing on things that are going to turn this ship around and stop people dying. So we in this field have a sense of urgency, and that sense is both to action in terms of interventions and treatments, but also in terms of research. We to think about something on a 10-year horizon is an awful lot of dead people between now and then. So we really need to think about things on a much shorter horizons and how we can do the best we can. And so we have a wonderful lineup of people from various areas of research that are going to paint a very interesting picture in the next 2 hours. We want to keep this a little bit loose. We want to give you a sense of who the investigators are, what kind of motivates them, and then we want to hear about their science. So we're not going to waste hardly any time introducing them. They're going to do some of the introductions themselves. And the first speaker, we're very lucky to have Lisa Marsh, PhD from Dartmouth, who's going to talk to us about digital therapeutics in the treatment of opioid and stimulant use disorders. Take it away, Lisa.
Terrific. Thank you. Thank you so much. Can you see my slides?
Yep.
Perfect. Okay. Thank you so much for the opportunity to participate in this important panel. And I just want to underscore the importance of the introductory comments and the situation we're in and the opportunity we have really to scale effective, literally life-saving treatments for folks struggling with opioid and stimulant use disorders. So briefly, I am currently at Dartmouth College in New Hampshire. I'm a professor there in psychiatry, and I head up a research center there funded by the National Institute on Drug Abuse called the Center for Technology and Behavioral Health. I'll tell you a little bit more about that in the presentation. I also have the privilege of serving as the director of what's called the Northeast node of a national clinical trials network that is funded by the National Institute on Drug Abuse. And we have the opportunity to work with many partners around our region in Vermont, New Hampshire, Maine, as well as many other pockets of the country. And glad to talk about that with any folks who might be interested. But briefly, I've been asked to talk about how did I get involved in this? So it seems like a lifetime ago, this is how I got involved. I was a student, I was an undergraduate student, and I had the opportunity to work as a research assistant at a phenomenal research organization called the Behavioral Pharmacology Research Unit in Baltimore, Maryland. Still there, it's still producing outstanding research. And it was the first time I was ever exposed to addiction research. And I was struck by at least two things. One was the incredible rigor of the work of this group. I mean, it was just, I'd never been exposed to research of that quality before, but also, I work directly, and I continue to work directly with folks who are really struggling with substance use disorders. And I was so struck by the chronic relapsing nature of this problem and how people, despite, desperately wanting to change their substance use, not doing so. And it just struck me as such an important behavioral and medical phenomenon that I really wanted to devote my career path to. And so that's how I got involved in this. And I'm heavily involved in lots of types of addiction research. And then, as I'll talk about today, a big part of our work is on leveraging digital health as part of models of prevention and treatment of substance use disorders. And the way I got into that was to think about how can we use digital technologies as one of many ways to enhance access to the state of the science of treatment interventions as well as prevention interventions. And so I'll give you a little flavor of that in my talk. So I will jump right in. In addition to my academic affiliation at Dartmouth, I have an affiliation with a couple of small businesses that are involved in digital health, developing tools and deploying tools for digital health. I'll mention our research center a bit at the end, but our center has been increasingly involved in academic, industry, and governmental partnerships to try to really scale up the best science. And I want to surely acknowledge the funding for the work that we do. We've been so appreciative to the National Institutes of Health, particularly most of our funding is from the National Institute on Drug Abuse, including our center grant, which just got renewed on Friday, which we're thrilled about, for our Center for Technology and Behavioral Health. So digital technologies, as we know, have fundamentally changed our lives and our society, how we function, how we do retail and travel and finance and social interactions. This has been transformed with the growth in web and mobile technology and cloud computing and data analytics. They've really fundamentally changed our daily lives. And a lot of our work is in the space of applying digital technologies to the health arena, this space called digital health. And in particular, I'm going to talk in this presentation about something called digital therapeutics. So digital therapeutics is a term that refers to clinical grade software that is effective in the prevention, treatment, or management of a disease or disorder. So these aren't simple sort of wellness apps or health promotion apps. Those have surely utility, but this is actually medical grade software. It's a therapeutic intervention that's of clinical quality that really produces clinical outcomes that are effective in preventing, treating, or managing a disease or disorder. So I'll give you some examples in the space of substance use disorders, but you could think about this as software that can embed intensive behavioral treatments that we know really help people change patterns of problematic substance use and learn new skills to support a recovery process. And it's all embedded in the software. So this can complement and extend telehealth models and such, but this is not synchronous communication with a clinician. It's literally an entire package of evidence-based care embedded in a digital delivery platform. And so it's all of the core functionality and the content of the software sort of embraces the active ingredients of a therapeutic intervention. So what is the promise of this? So if you have software that really can be effective in the prevention, treatment, or management of a disease or disorder, this could be another tool in the toolbox of clinicians that can enhance the reach and the impact of the work that clinicians do. It's kind of like a clinician in your pocket. It's 24/7 accessible. And what we've seen in lots and lots of health domains, including but beyond substance use disorders, is that these tools, if developed well and really engage people and provide sort of state of the science treatments, can really greatly improve patient outcomes when they're part of models of care. We also know, and this is incredibly important, that these tools can deliver treatment with fidelity to best practices. So we know there's a lot of variability in care models out there. We know that we can take the most science-based approaches and embed that in the functionality of how these types of digital treatments work. Although it's the case that not everybody in the world yet has access to digital technology, we know that people have been exponentially gaining access to mobile technology all over the globe, and that's expected to continue to grow at a rapid pace all over the world. And this is true in even traditionally disadvantaged or vulnerable populations. This is true even in some of the low and middle income countries that we work in as well. So the idea is that these are tools that can offer scalable, science-based therapeutic interventions anytime and anywhere. And in the space of substance use disorders, the application of digital therapeutics has been shown to markedly increase retention in substance use treatment, as well as increase abstinence from problematic substances among patients who are in substance use disorder treatment. So when this is added to the care model, we see it increases multiple sort of clinical outcomes, but we've really seen a robust effect on retention and drug-taking behavior. And of course, the importance of this is, arguably more timely and significant than ever in this world we've been living in the global pandemic, where many care models have shifted to remote models or partially remote models. And there's just been a surge of interest, not just in telehealth, but also in the interest in these digital therapeutics as part of models of care, not only clinically, but also if you look in sort of the investment arena, globally, including in global pharmaceutical companies, we've seen a big surge in people's digital health formularies and their engagement in digital therapeutics. So what I'd like to do now is give you one example of a digital treatment for substance use disorders that I and some colleagues had a chance to develop the first iteration of it many decades ago at this point, and it's been studied for a couple of decades in NIH-funded research. And it's an example of taking a behavioral treatment for substance use disorders and deliver it in a digital platform. I'm going to tell you briefly what it is. Happy to talk about it more, but the point here is to illustrate when you apply this in different ways to care models for addiction treatment, what kinds of patterns of outcomes you might be able to see. So the research version of this particular intervention was called the therapeutic education system. And again, it's a digital therapeutic specifically for treatment of substance use disorders. It is an interactive, again, digital intervention. It started web-based, right? Now it's, of course, available on mobile platforms, but it's based on a very strongly empirically supported behavioral treatment for substance use disorders called the community reinforcement approach to substance use disorder treatment. And just briefly, this is a really powerful treatment model that helps people not only understand and disrupts harmful behaviors and cognitions that might perpetuate self-defeating patterns of drug use, but to really leverage lots of resources, personal, social, vocational resources to help people change problematic substance use and maintain those changes. And it also flexibly includes what's called a contingency management component, where people can get incentives or rewards contingent on some successes in treatment. Maybe that's providing a urine sample that's negative for a problematic substance. Maybe that's participating in a therapy session. This has a lot of empirical support for all kinds of substance use disorders. It is actually Can you still hear me? I have a message saying I'm muted.
I can hear.
Yeah, you're back now. You were
Okay.
gone for a moment.
Okay, sorry. Okay. Hopefully this will continue to work. And that's also been really shown to be effective as part of models of treatment for opioid use disorder, and has synergistic effects with medication treatments for opioid use disorder as well. So we took this really strongly science-based model of treatment and developed an entirely digital version of this, which is this digital therapeutic education system that I mentioned. And it's pretty intensive. It has 60 some different components of therapeutic content that really help people in learning skills and having tools available to them that can help them initiate and maintain changes in their substance use behavior. There are lots of different sections of the therapeutic content. Happy to talk about it more, but in the interest of time, I'm just going to jump into some of the outcomes that we see in research that's used this particular digital treatment. So the first of the studies I'll briefly mention was done with adults who met criteria for an opioid use disorder, who were all entering outpatient treatment for their opioid use disorder. And everybody in the study received medication. Everybody received buprenorphine medication to stabilize brain neurochemistry. And we know that's literally life-saving as part of treatment models for opioid use disorder. But what we randomized on in this 3-arm study was the type of behavioral treatment people received along with the medication. So 3 conditions. If you went into the condition that's reflected here in the blue column, or perhaps that's purple, you received individual counseling with a therapist 3 times a week, one-on-one counseling sessions in which that clinician was trained to deliver with fidelity this science-based community reinforcement intervention with contingency management. If you went into what's reflected in the red column, you had a counselor, you checked in with them every other week, but instead of having that intensive therapeutic interaction with the counselor 3 times a week, instead you went to a lab at the healthcare setting where we did this work, and you interacted individually with a digital version, an interactive digital version of the same community reinforcement treatment. And then if you went into what's reflected in the gray condition here, the gray column, that was reflective of standard treatment that was provided in US-based opioid treatment programs at the time the study was done. So there are many results from all of these studies. I'm trying to give you a snapshot of some of the patterns of findings we have seen, but what you see here is that even when you offload the bulk of the therapeutic intervention to a digital platform, you get comparable clinical outcomes to exclusively clinician-delivered care, a clinician-delivered version of this state of the science gold standard treatment. And both of these produce outcomes that are better than standard treatment. And this is as measured by objective urinalysis testing specifically for opioids and cocaine, which were problematic substances in the sample. I'll give you 2 more examples. Here's another study we did in an outpatient treatment setting with adults, again with opioid use disorder, who were entering treatment in a methadone treatment setting. So everybody in this study received methadone medication, a daily dose of methadone medication. People who were in treatment as usual, which is reflected here in yellow, they also, were offered the kind of counseling provided in a methadone treatment setting. And if you were randomly assigned to this condition, you still got your methadone medication, you had a counselor, but your patient clinician time was cut in half, and half of that was replaced with access to the digital treatment. So instead of meeting with their clinician for, let's say, 60 minutes, they'd meet with them for 30, and then they would use the digital treatment, this digital version of the community reinforcement approach to treatment for the other 30 minutes. And when we cut in half counselor-patient contact time and replaced it with a digital treatment, we had markedly greater weeks of opioid abstinence in that sample compared to the sample that got standard treatment. And we have lots of other data from this study, even showing that this effect persisted for 12 months. We had the chance to observe outcomes for a year, and we had this differential for a year. And there's lots we could say about this, but just briefly, this is a way, we think what's driving this is a way to ensure that we're delivering one of the most effective, if not the most effective behavioral treatments in a way that ensures fidelity, that's very interactive, responsive to that patient, and really helping people learn skills and be successful in this in a treatment process. And so this we've now seen replicated in this type of pattern of results we've now seen replicated in other studies. And then just final example of a research study that I'll highlight here was conducted on the National Institute on Drug Abuse's National Clinical Trials Network. So it was a multi-site study with sites all over the US, all running the same protocol, evaluating the utility of this digital treatment as part of outpatient treatment for substance use disorders. And this included a really diverse array of substance use disorders, polysubstance use, lots of folks with stimulant use disorders, cannabis, alcohol, lots of combinations of substance use, folks entering outpatient treatment for a wide array of substance use disorders. And so let me just walk you through this slide. At the top 2 lines reflect people who were in these outpatient programs who at the time that they joined this study already had some stability in their recovery process. So they're coming into this clinical trial already able to provide urine samples that are negative for their problematic substances. And in that sample, when you add the digital treatment, which is a top line here, to their care model, you see a very slight bump where you get a little bit of an increase in abstinence for them over time when the digital tool is part of the care model versus when it's not, which is this line. But the much more robust effect we see here These are people entering the clinical trial who are actively using substances. When you add the digital treatment to their outpatient model of care, which is reflected here, you see that they have much more of impact in terms of increasing rates of abstinence from problematic substances when this tool is part of their care model versus when it's not. So it's roughly doubling abstinence rates when it's part of the care model for that sample of active users. And again, lots of room for improvement here, but this is a really a market effect. We've seen this also replicated in other studies where people who have the highest sort of risk profile, some of the hardest maybe to treat populations when they're entering treatment, when you offer digital treatments as part of their care models, we see that they are among the groups that benefit the most from those types of treatments, although these digital treatments have not been shown to be contraindicated for any population at this point. So just briefly, if you haven't heard this yet, you may be interested to know that we've seen in the US that there is now a new category of medical devices that the US Food and Drug Administration authorizes as what's called a prescription digital therapeutic. So it's in the category of medical devices, but the FDA receives basically data from clinical trials looking at safety and effectiveness of a digital treatment that's seeking to get a label that says it is effective in the prevention, treatment, or management of a disease or disorder. And if you meet all the criteria of the FDA, and there are numerous criteria, you can get the status of FDA authorization as a prescription digital therapeutic, which literally means that people can prescribe software. So you could be a primary care provider prescribing software for mental health, prescribing software for substance use disorders as part of the array of services that you can offer to patients. So the first one that the FDA authorized was in September of 2017. It was a mobile version called Reset of the tool I just described to you. And then there was another version of this in 2018 that the FDA authorized specifically with an indication for the treatment of opioid use disorder, and it's called Reset-O. But now there have been an array of FDA authorized, I think there's at least a half a dozen that are now authorized in the US that have this status. Most are in the space of mental health, and many were approved and released last year during the COVID pandemic, where the FDA somewhat lessened their criteria to get approval to make more mental health therapeutic resources widely available. So in closing, as we think about this, striking need we have around our nation, around the ongoing opioid crisis, and now, compounded with the stimulant crisis, and that's touching, so many pockets of our nation. I'm not suggesting that these digital treatments are the solution to our challenges, but I think that the data are very compelling, that they might be important as part of multi-component models in providing effective and accessible treatments and really helping to scale, right? Helping to enhance the reach and the impact of science-based treatments, and to really think about impact that we can have at a population level that can transcend lots of different contexts. So I'll stop there. This is our website for our research center. We work to provide lots of resources nationally and internationally around this space of digital health as it relates to substance use disorders and also mental health. And we encourage you to check out our website or follow us. We have very active social media presence as well, and would be happy to follow up with any folks who might have interest in learning more. So thank you again for this opportunity to present today.
Well, this is really fantastic work. And I think it speaks to two things. First of all, we have a manpower issue. A single person, if you think about a single person in your neighborhood, a young person overdosed and dies, and you look at everyone in that neighborhood is impacted. All the dozens and dozens of people in that patient's family are all impacted in a way that's going to last them for the rest of their life. Anybody walking by that house is going to kind of look down for the next 40 years, think, oh, what a tragedy happened there. The classmates in school and the coworkers. And so we really need to invest the kind of individualized services and care and tailored care to each individual. And so we're running into a manpower issue to give that kind of service to that many people. And this is a wonderful way to leverage what can be done on a manpower, a one-on-one for 3 times a week can be done digitally. That's is very exciting. The other thing that jumps out at me is the difference between people who've been in for a while and people who are just starting in. And it seems to me there's, when people, it depends on where you look at people in this trajectory. I mean, I spend a lot of time seeing people in the correctional setting, and they've been around the barn. They've been around all the barns a long time. And, they've, you can give them messages, but they've kind of heard them already. You can try different things to engage them. Whereas somebody coming fresh in off the street, they might not know anything about this disease and how to deal with it and what's happening to them. I mean, they're kind of just buffeted one way or the other, and so some of the kind of straightforward tools and messages and understanding that you can impart to them are actually going to be much more effective if you catch people at the right time. Do you think that's what's going on there?
I think so. I think to your first comment, I think these can sort of supercharge the clinician workforce that we have, right? We have a challenge with, capacity to really meet the population level needs we have, but this can be a way to enhance the reach, I think, and impact of what the clinician workforce offers, and can complement and extend it and provide, literally, as you said, resources accessible on demand 24/7 that can really help people in the moment, in their daily lives, in the process of recovery. And I think in the justice system, as well as many other settings, we've seen that this type of tool can have value. And I just highlighted, that what we've been able to look at in the addiction space, but we have seen there's been a pretty large growth in really rigorous research in the space across all kinds of health domains. And we have seen that this has very similar kinds of patterns of sort of replicable and robust effects we can see across all kinds of health domains. So it really seems like it generalizes, more broadly beyond sort of the behavioral health arena.
Well, I'm going to jump in there to see if I can help keep us on time here. So and make sure Eli, our next speaker, has time. So does that work for everybody?
Yeah, thank you, Steve.
Thank you much. One thing I would just say, Lisa, that we're going to send young investigators interested in this field to reach out to you.
We would love that. Please do. Thank you.
Wonderful.
Okay.
Thanks a bunch, Lisa. So our next speaker is Elias Klemperer from the University of Vermont, one of my dear colleagues. And the title of his presentation is Preliminary Findings from a Statewide Evaluation of the Implementation of Medications for Opioid Use Disorder in Vermont Correctional Facilities. Eli?
Thanks, Steve. I will share my screen here and see if we can't get these slides up. If people can't see that, please let me know. So I was booted earlier and missed the beginning of these presentations, but we were asked, I believe, to share a little bit about ourselves in the beginning here. So I'll start by introducing myself. I'm Eli Klemperer. As Steve mentioned, I'm a research assistant professor at the University of Vermont Center on Behavior and Health, funded by the COBRE Center that Steve directs. And what brought me to this research was really researching broadly treatments for addiction with actually a focus on nicotine and tobacco. But my clinical work, I'm trained in clinical psychology, focused primarily on people who are incarcerated in the treatment of opioid use disorder. And so I was lucky enough to get funded by the Justice Center on Opioid Innovation Network, which is NIH HEAL, to do an evaluation of the implementation of medications for opioid use disorder in correctional facilities, which was an opportunity to bridge my research and clinical interests. And that's what I'll present to you today. So before I get started, here's my disclosure and funding information. And a little background on the topic. So as many of you are aware, the opioid epidemic has devastating effects in the United States. And in the Northeast, we're not immune to this. In fact, Vermont is ranked 11th in terms of opioid overdoses per capita at about 22.8 per 100,000 people. And unfortunately, this trend has continued in recent years and increased and continues to increase with the ongoing epidemic. pandemic of COVID-19. And you can see here in this graph, this is largely driven by fentanyl use, but continues overall to increase. So among people who are incarcerated, they're particularly vulnerable to the harmful effects of opioid misuse and overdose. In fact, overdose is a leading cause of death upon release from incarceration, with some states up to 12.7 times more likely for individuals to have an overdose within the first 2 weeks of release from incarceration compared to age-matched controls. So this is an incredibly vulnerable time for a vulnerable population with regard to opioid misuse and overdose. Fortunately, as many of you are aware, we have effective medications for opioid use disorder. These are buprenorphine, methadone, and naltrexone. Some of you may know buprenorphine as Suboxone, but most people who are incarcerated don't have access to medications for opioid use disorder. So there have been calls for, and now a few states that have implemented medication for opioid use disorder for people who are incarcerated, with one major benefit being the continuation, or ideally the continuation of care after release from incarceration, and reducing overdose after release. Some of the folks on this call, Jody Rich and Dr. Jody Rich and Dr. Green, have led the effort to evaluate that in Rhode Island, which was the first state to implement medications for opioid use disorder across their correctional facilities. And Vermont soon after passed a similar act to implement medications for opioid use disorders for all people incarcerated who met medical necessity for these medications. It instructed the DOC to provide MOUD as soon as possible and as long as medically necessary for folks who are incarcerated. And it prioritized buprenorphine, or Suboxone, as the frontline treatment for people who are incarcerated. This was passed in May of 2018, and implementation began in July of 2018. And there's a report due to the legislature in 2022. And what I'll present to you today are some very preliminary findings that will go into this report. Now, there was another major event in our state, as well as across the world, that very likely affected the treatment of opioid use disorders, and that is COVID-19. And so the state of emergency was declared in March, and everything had changed. So in the correctional facilities, we have daily medical screenings, increased social distancing, tests for everyone who, all intakes, and then personal protective equipment and changes to medical procedures. And though it's not an official policy in Vermont, there was a rapid decrease in the overall incarcerated population. So you can see here, I've highlighted March, and you can see after the state of emergency was declared, a precipitous decline in the incarcerated population that continued on and is still decreasing. And so all of this is to say that it's very likely that these changes had substantial effects on the treatment of opioid use disorder. So this set up a situation where we could use, or we are using, administrative data to look at pre versus post these important time points to see how treatment for opioid use disorder has changed for people who are incarcerated. And so we're looking at 3 time periods in particular. The period A, which is pre-implementation of these medications, and pre-COVID, period B, which is after the implementation of medications for opioid use disorder, but still pre-COVID, and then finally period C, where we have both medications in the facility during the ongoing pandemic. So I'll talk to you today again. These are very preliminary findings. We received the data from the DOC and our Medicaid claims data just a couple of weeks ago, but there are overall 2 data sources we're using. First is statewide Department of Corrections administrative data, and the second is Medicaid claims data, which follows people who were incarcerated after they were released from incarceration. I'll talk to you a little bit about change in the use of these medications while incarcerated, change in the use of medications after release, as well as emergency department visits, and then overdose data. So first here is our population. We have a little over 5,000 in groups in time periods A and B, individuals who were incarcerated for 1 or more nights during those time periods. Smaller population in time period C, largely due to the decline in incarcerated population after the onset of COVID-19. So to begin with, I'll show you a snapshot of the prescription for opioid medications for opioid use disorder in correctional facilities. So this is the percent of all people incarcerated during these 3 time periods. You can see in time period A, before the implementation, almost no one was receiving these medications. And then as expected, we saw a large increase, or we're seeing a large increase in the prescription of MOUD. The blue bar is any MOUD, and then you can see the vast majority of these medications is buprenorphine in both time periods. Seems to be a small, but we have not tested this with a statistical model, but a numerically small decrease in the prescription of MOUD with the onset of COVID-19, as you can see here between time periods B and C. Now, there are a number of ways MOUDs can be prescribed. We have people, the blue bars represents people who continued their medication upon incarceration. So people who were receiving treatment in the community continued when they were incarcerated. The red bar is particularly interesting. These are folks who were not engaged in treatment in the community and then initiated medication for opioid use disorder upon incarceration. And then green represents people who at some point during their incarceration were discontinued from medication for opioid use disorder. There are many reasons why this happened. We're digging through those data now to categorize them, but it's looking like the most common reason was due to diversion and forced discontinuation by the correctional facilities. Again, you can see some slight decreases in continued and inducted on MOUD from the time periods B to C, although we have not yet analyzed these data to look for statistically significant changes. So then looking at the Medicaid claims data, and this follows folks after release from incarceration, we're looking at a specific subset of the incarcerated population with these data. So these are people who received an OUD diagnosis from a Medicaid claim within 3 years prior to their release from incarceration. And then we followed them via Medicaid, or we were using these data to follow them via Medicaid after release from incarceration. So it's a much smaller sample here. Again, these are only folks who had an opioid use disorder diagnosis from Medicaid within 3 years of their release. So looking at this important outcome here, this is the percent of people who received medications for opioid use disorder within 30 days after release from incarceration. Again, this is this incredibly vulnerable window when overdoses are so high. So we really want people to be engaged in treatment during this time period. We can see here in our period A, so this is before the medication for opioid use disorder was implemented in correctional facilities, about a third of people with a history of opioid use disorder were engaged in treatment within 30 days after release. This number statistically increased, significant increase to 41% after the implementation of medications for opioid use disorder for people who were incarcerated. And then we see numerical but not statistical decline in the percent who received medication after release from incarceration during the pandemic. Worth noting that the overall change from time period A to C was a significant increase. So one interpretation is COVID-19 may have attenuated some of this effect, but it didn't return it all the way back to pre-MOUD levels. And I also wanted to present some data on emergency department trips within 30 days after release from incarceration. Again, this is only this is Medicaid claims data among people who had an OUD diagnosis. We can see here numerical but not statistical increase in emergency department trips from time period A to B, and then a significant decrease with the onset of COVID-19. That decrease was also significant when comparing A to C. So that's the change with both COVID-19 and MOUD. So now I want to move on to overdoses and what we're seeing, again, preliminary findings in Medicaid claims data. And this is overdose within 30 days after release from incarceration. I want to draw your attention to the vertical axis here. These are very small numbers, but we do see some substantial changes. We have not analyzed, we've not conducted the statistical model to look for significance here, but you can see a substantial decline in non-fatal overdoses between time periods A and B, after the implementation of medication for opioid use disorder in correctional facilities, and then what looks like a rebound from time period B to C with the onset of COVID-19. So again, these are non-fatal overdoses within that 30-day window after release from incarceration among people who have a history of opioid use disorder. And then looking specifically at fatal overdoses, and the time period here we extended to 1 year after release from incarceration. Again, very small numbers here, but we do see a decrease, a numerical decrease from time periods A to B after the implementation of medication for opioid use disorder in correctional facilities. We don't yet have the full 2021 data set, although these data will be available for our longitudinal analysis for our 2022 report. Stay tuned for that. So I want to summarize this and then talk about our next steps here in this evaluation. I think some of the important, very preliminary findings here is that we're seeing similar to what the Rhode Island groups found, MOUD implementation is associated with increased MOUD in the community as well as decreases in overdoses after release from incarceration. One sort of preliminary pattern we're noticing here is that emergency department visits appeared to decrease after the onset of COVID-19, despite an increase in non-fatal overdoses. One concern, as others have seen across the US, is maybe fewer people are seeking care despite increases or potential increases in overdoses. So there are a number of important next steps here. Broadly, we are in the process of analyzing the data longitudinally. So rather than these sort of crude bins comparing A to B to C, we'll look at this as a continuous data set and tease apart the effects of these two events, MOUD and COVID-19. And then we're also conducting a series of qualitative interviews over the next year with folks who are incarcerated and currently receiving medication for opioid use disorder, as well as a sample of DOC administrators and healthcare providers within the Department of Corrections. So we have a fantastic team here at the University of Vermont, Steve Higgins, Rick Ross, and others. And then really none of this is possible without collaborators in the DOC, Annie and Jess, and then Blueprint for Health. These are the folks who manage the Medicaid claims data. And then we also have great support from J-Coin with Liz Evans at the University of Massachusetts. So thanks to all those collaborators. And I would be happy to take any questions that folks have. Thanks.
Yeah, thanks, Eli. That was a wonderful presentation. I was just struck by your data and pre offering of medications to the incarcerated population to post. So like 1/3, once the medications were available, 1/3, if I read your data correctly, 1/3 of the population was on medication, where prior to the legislation allowing that to happen, they were receiving nothing. Am I reading that correctly?
Yeah, absolutely. So, I think, there's been some really great work in this area by Dr. Rich and Dr. Green to show how, people who are incarcerated in states where this isn't available really have no access to these life-saving medications, which puts them at real vulnerability when they're released back into the community where the illicit opioid are much more readily available.
So I want to ask you a question about the data then on release, because the number of people who were medicated upon release wasn't so different between the two time periods, before there was any medication in the prisons and then afterwards. And so is it that you're losing a lot of the people who were medicated during incarceration? We're not getting them engaged into medication treatment following incarceration?
I think that's the crucial question. So you're right. We're seeing about only an 11%. Well, again, these are sort of crude initial findings here, but only about 11% increase in the proportion of people who receive medication after release, pre versus post onset of MOUD, which seems small given the huge increase in correctional facilities among people who are already on this. And so we're trying to drill down now to find out how we're losing people and what happens to those folks who were medicated and then returned to the community and are getting off of their medication for opioid use disorder, and why. And then I think from that leads the important question of what to do about it.
Mhm, mhm. Anyone else have any comments? There are plenty of people in the audience, Tracy and Jody, who know a lot more about this topic than I do.
I know Jody's going to have a question, or others too, but I posted one in the chat for you. I don't know if Eli, if you can see that one, but I just was curious whether people who are continuing to treat and to receive care post-release, were there different, it's fantastic and so exciting to see such high rates of continued care. I'm just wondering about folks who are inducted versus those who are continuing their care seamlessly, and if there were differences there, and maybe you'll see in the qualitative interviews too, if there are differences, maybe what do those folks who are inducted kind of need as extra supports perhaps, but just.
Yeah, no, I think that's exactly where we need to go with the analyses going forward. So I haven't yet looked at differences, if I'm understanding the question correctly, differences between people who were inducted upon incarceration versus continued medication upon incarceration. How do they differ in terms of their continuation of care after release from incarceration? Yeah, I think that's a really important question to ask, especially yeah, for a number of reasons. And we have the data to look at that, but haven't done it yet, but we'll be looking at that.
Very exciting. Great job.
Yeah.
Joseph, I'm sorry.
A very, very impressive data and presentation. So I think at this point we're ready for our next speaker, Dr. Tracy. Tracy, are you going to do the honors of introducing Joe, or is that Jody?
I'm actually happy to, but I will do that very quickly because I did see Dr. Tracy had his hand up with a question. So
oh yeah,
maybe
well he can ask his question when he gets
at
on.
the same time.
We'll
Please
come
see
back.
It's actually more of a comment. I was impressed with that one figure that showed the baseline, and Steve was noticing that as well. I think from B to C, your N dropped from I think what I saw was like 3,100 people dropped out, but despite that, the numbers were exactly the same. The percentages were exactly the same. I don't think you can find anything else that speaks to the validity of the data that you do have. So it's more of a comment than it is a question. Anyway, so all right, so I guess let me see.
So we haven't really introduced yet. I'll do it.
Thanks, Steve.
Joseph Tracy, who is a professor at St. Anselm College in New Hampshire, and the title of his presentation is What Might Extinction, Spontaneous Recovery, Reinstatement, and Renewal of Behavior Under Discriminative Control by Interoceptive Stimuli reveal about the nature of relapse? And so Joe is going to take us into the preclinical laboratory we've been sharing research up to now from the clinical lab, from the clinical setting. So Joe, have at it.
Thanks, Steve. So you had asked to be casual about this and talk about background and how did we get into this line of business. And my story is actually kind of interesting. I kind of feel like I've gone full circle in many regards. But I'll start with the idea that, like most of us who majored in psychology, we wanted to be clinicians. And then something magical happened when I met a guy named Phil Heinlein when I took psych of learning, and I quickly wanted to study the behavior analysis, and specifically the experimental analysis of behavior. And that led me to graduate school, where I worked with Phil Bursch, also a behavior analyst, but more of a Pavlovian operant interactionist. And at the time, I was enamored with the means by which classical conditioning can be used to play a role in immunology, drug addiction, endocrinology, and so many other biological types of responses that have important implications for medicine and psychosomatic medicine for that matter. However, I ended up taking a postdoc at Johns Hopkins. I'm the second BPRU, I think third, because Steve is as well, BPRU grad. I worked with Roland Griffiths, and that was an interesting trip, no pun intended. He was a great guy to work with. I learned an enormous amount of skills during my 2 years there. We had our first daughter there who just got her PhD there. So I end up at this small college 29 years ago and wasn't planning on staying beyond the 3-year period, but I got comfortable. They offered me tenure. They gave me a lab. Well, they gave me startup money to get the lab going. And being at a small college, I ended up working with students. So I'm going to start with that. And these are my current students who worked this past summer under the New Hampshire INBRE project. I was asked by INBRE to give this presentation, so I'm happy to do so. So these are our current students. I won't name them all, obviously. And these are our rats. We have male and female rats. We're studying sex differences currently on nicotine sensitivity and some of the things I'm going to be talking about today. So we have a real facility. We give them enrichment on a regular basis. This is our animal technician. And this is my lab that is actually set up for my psych of learning class. It became a lab that I use to actually conduct most of my work. I do have chambered cubicles in the other room. I'm not going to show you data from those, but we've been using this for for 20 years or so now. So these are this is our operant chamber. It's a sound and light attenuated room. It's lit with red light. And there's another one. This is Nicole weighing out some nicotine. And so, yeah, we're all about our students. So many years back, I had a student who heard me talk about drug discrimination in my psych of learning class. And she wanted to do a drug discrimination study with caffeine with rats. So back then, it was all about going to the library and going and doing the work that way and looking in Psych Info and Medline. You know how it was back in 1994 in terms of getting information. But she did a good job. She found some work by Stephen Holtzman on caffeine and some work by Roland Griffiths on human caffeine discrimination. And her idea was to study it in a T-maze, which we did. And we used Fruit Loops as a reinforcer. And she found that the rats could discriminate based upon, well, one rat could discriminate it. And from there, using the operant chambers, I thought, how can I do drug discrimination work using one lever as opposed to the standard assay that utilizes 2 levers? Well, I went back and talked to Don Overton and met a very important colleague by the name of Toby Yarbe, rest in peace, who passed away a few years back. He was one of my mentors. And Don Overton was all about looking at the psychological aspects that play a role in stimulus control in drug discrimination. So I just latched right onto that because my background was in classical conditioning and operant interaction, as well as looking at the interface between the 2 forms of conditioning with regard to various types of stimulus control phenomena like blocking and overshadowing and second order conditioning and operant chaining and all of that. And I thought about what could I offer this. So this is just some quote from Don. And I start with the idea of basics. Let's talk about the 3-term operant contingency. Most of us know that the SD, a discriminative stimulus, sets the occasion for some response to lead to a consequence. Most of us also know that this is easily applied to drug-taking behavior, which is admitted voluntary behavior, although influenced by Pavlovian processes. I argue that those Pavlovian processes are neither necessary nor sufficient for promoting relapse. However, with regard to stimulus control at least. However, behavior does produce an outcome, and we talk about it as action-oriented behavior and the associative lingo. So a behavior produces a reinforcing consequence, commonly known as the 2-term contingency. With regard to drug taking, we think of picking up and drinking a beer as producing an alcohol effect. Inhaling tobacco smoke produces a nicotine effect. I think most of us all already understand that. However, as I mentioned, there's also the third contingency, or third term in the three-term contingency, and that is the discriminative stimulus highlighted here. And so that would be an environmental event, but the environmental event can also be internal, so it would be interoceptive. But in the case of an exteroceptive cues, we think of the presence of an actual beer, occasions picking up the beer and consuming the beer, presence of a friend who offers a cigarette, sets the occasion for smoking a cigarette, and then, of course, obtaining the nicotine effect. This, by the way, can be an extended, long, operant, heterogeneous chain that's maintained by condition reinforcing effects of stimuli that are so distal from the actual reinforcing outcome, in Pavlovian terms, the US. So I start with that idea. And so for the past 20 years or so, we've been focusing primarily on extinction of that three-term contingency, but using an internal discriminative stimulus. So first, let's start by talking about extinction. Most of us know that a behavior is acquired. It can be extinguished by eliminating the consequence. There can be a delay period afterwards, and then lo and behold, we get a little bit of recovery, which begins to dissipate. And with prolonged extinction, you see less and less recovery over time. Pavlov was actually the first to coin the phrase silent extinction, that it occurs long, extinction continues to take place, even though there's zero level responding. Okay, so that's where the parallel with cue exposure therapy ties in, which doesn't work, and it doesn't work for many reasons. And I'm not going to go into all that, but I will say that cue exposure therapy really hasn't taken advantage of looking at interoceptive states, which also influence drug-taking behavior. So we have things like hunger, general motivation, anger, general arousal, depression, boredom. Alcohol craving is partly mediated by thirst, fatigue, all of these things. In 12-step clinic, 12-step programs, people are told to avoid the acronym HALT: hungry, angry, lonely, thirsty, and tired. Those are all common interoceptive cues, which can, using an operant term, provide a motivating operation to then become more sensitive to discriminative stimuli that occasion drug seeking and then drug taking behavior, or procurement or consumption, as Mark Boughton talks about it. So what is drug discrimination? Drug discrimination has been an invaluable pharmacological assay used to evaluate basically receptor theory. So if we train an organism to discriminate, say, morphine from non-drug, and then we test a mu agonist, we're going to get pretty much full substitution for it. Whereas if you substitute something that acts on kappa, delta, or delta, you're going to get virtually no substitution. Well, that's all good. However, it's also a behavior analytic tool that's been used to actually evaluate interoceptive states. And that's where I'm operating from. And that's where I'm coming from now. So we've been using a one-lever procedure, as I mentioned at the outset, where the animal engages in an operant instrumental response and then obtains the reinforcing consequence. In this case, it's an appetitive reinforcer, food, which acts on the same general areas of the limbic system that drugs do, and eventually it's in dopamine release and all that sort of good stuff. But we also have conditions where another drug or the non-drug state can function as what's commonly known as the S-delta, which signals that these sessions do not culminate in food. Drugs A and B, or drug and no drug, are counterbalanced for their roles to control for the unconditioned effects of drugs. And so the data I'm about to show you, I have no time to get through all of it, but I'll pick some things that get my point across. Will show that there are two different conditions of animals, those that receive nicotine in this case, that signals food availability, and animals in which nicotine signals non-availability, or therefore functions as an S-delta. So our first publication on this came out in 2003, published in Psych Record. It was a nice first journal to go to. It was very basic data, And what we did was, I'm not going to show you the acquisition data, but I am going to show you the extinction data. And we have 4 groups. The groups to the left here, the 2 groups to the left had nicotine functioning as an SD, and the 2 groups to the right had nicotine functioning as an S delta, or saline functioning as the SD. And what you're seeing here is the sum of responses across many, many sessions where we alternate between nicotine and saline. And you'll notice that there's an obvious extinction curve that begins to occur. And I want to call your attention to the arrow here that occurred after 2 S delta sessions. We have recovery right there. But after that, there's none. Whoops. And that happens for all 4 of these groups. Now, the 2-week and 4-week conditions have to do with the delays that occur where we test spontaneous recovery and reinstatement after this 24th extinction session. And I'm going to show you those data. So these are our baseline training data, very good acquisition, 98% nicotine responding, 95% nicotine responding. Actually, if I look at nicotine responding here, it's 5%, and over here, it's actually 6% if I only focus on the nicotine, meaning that nicotine is suppressing responding here, and nicotine is promoting responding there as an SD. After extinction, we see this. This is following the delay, and this shows that regardless of the delay after extinction, there is no recovery. But if we prime them with a food pellet, series of food pellets on the next session, we find, in fact, that nicotine promotes responding, we get recovery, and there is no difference between the 2 and 4-week delay. And nicotine also continues to suppress responding here. And focus on that suppression right there, the square down here as well. So we did another study with alcohol, nicotine versus alcohol, and I'm just going to quickly show that this is our baseline. This is what happens when you extinguish the response independent of the drug state. That is to say, in the presence of saline. This is what happens when you extinguish the behavior in the presence of the drug states. This is what happens 2 weeks following that extinction. This is what we have following reacquisition. And then following extinction again, a nice ABA design. And then following 4 weeks, we get a little bit of recovery. It is statistically significant. And that's what I have to say about that. So far, extinction of the response in the absence of an SD does not undermine stimulus control. Extinction of the response in the presence of the internal SD will disrupt stimulus control, and that appears to be stable over time. There's something fundamentally different about interoceptive SDs versus exteroceptive SDs for that matter. And the interaction between the 2 is very critical for drug treatment and understanding relapse, because we have a montage of different cues that at one point may have signaled behavior. And if we only focus on a few of them and then let the others go by the wayside, you know, like Rich de Grand Prix suggested in the paper that talked about equivalence classes, there's a unique way in which stimulus control can emerge in such a way to promote relapse. So reinstatement does occur. I'm not going to comment on that. We did some Pavlovian stuff where we carry out acquisition. This is actually acquisition data. And then we exposed them to the drugs either in their home cage or in the operant chamber without the ability to respond for the reinforcer. So this would constitute a Pavlovian extinction procedure. We compared that nicotine and alcohol and found that, in fact, interestingly enough, that we did get suppression of responding by Pavlovian extinction alone with nicotine, but not with alcohol. And that actually surprised us. But when we tested them when they were given the drug in their home cage, there was no extinction that occurred. So presentation of nicotine but not alcohol in the training context, but not home cage, reduced stimulus control. We did a study that involved reinforcer devaluation. In operant terminology, that's commonly known as an abolishing operation. Food pellets don't just function per se as reinforcers. They only function as reinforcers under certain conditions, just like drugs. They only function as reinforcer under certain conditions, right? A sedative isn't going to function as a reinforcer in a condition where you're engaged in hypervigilance. Speed isn't going to function as a reinforcer when you're under a condition where you have to relax. Ken Silverman taught us that a long time ago, that the work requirements play a role in modulating the reinforcing efficacy of a stimulus. So if we simply sate the animal, we're going to devalue the reinforcer. We're going to demotivate, if you wish. In a way, that's what methadone maintenance is. It's just devalues to some extent the reinforcing value of an opiate. However, it's qualitatively different because the route of administration is totally different. And the actual direct effect is qualitatively different. It's sort of like having a chocolate food pellet versus a grain-based pellet. The grain-based pellet might take the edge off, but there's always a little bit of room for Jello, just like there is for even people on methadone. There's always, when they're low in their cycle in terms of when the drug's wearing off, they're more vulnerable to drug-related cues, as the group at Penn has showed us. So I'm going with that kind of operating.
Hey, Joe, it's Steve. Just a quick heads up, you're largely out of time. So if you could wrap up, make sure Dr. Park has sufficient time. Thanks.
Okay. So, we sated the rats, and extinction was horrible. When they were put back on food feeding restriction, we got a complete return of stimulus control. We showed that we could transfer it to different responses, that stimulus control transfers to different responses, and it can modulate operant chains and can promote recovery in those chains. When we combine drugs and then extinguish one element and combine them again, we get recovery. So configurations of stimuli is important. And we've been doing a lot of work evaluating extinction and looking at relapse. These blips that you see here are actually individual rats showing spontaneous recovery after long periods of non-responsiveness. Very akin to what happens with relapse and the individual differences. So I guess I'll wrap it up there. We did some sex difference work with nicotine using olfactory cues, and I'll just finish with this. Interoceptive states modulate goal-directed action in both a facilitative manner. Interoceptive states modulate behavioral chains, which may be conceptualized as drug-seeking and drug-taking behavior. Interoceptive stimulus control transfers across behaviors, which is analogous to different drug-taking rituals. Smoking cocaine different from snorting cocaine, shooting heroin versus eating it. And then multiple internal states can combine in unique ways that can promote recovery. And that's all I want to say. I'm just going to show off my lab, and thank you. Thanks to New Hampshire INBRE for the continued support. And I'll take questions.
So we may have time for one question for Joe. Excellent. Let me compliment you, Joe, on an excellent presentation that lets us see the precision and rigor of the preclinical laboratory. It's really a pleasure to see. Anyone have a question for Joe? Then I think to make sure that Dr. Park has sufficient time, I'm going to turn the mic over to my colleague, Dr. Green, who is going to introduce our next speaker.
Wonderful. Thank you so much. And wonderful also to see such a nourishing laboratory and space, Joe, for budding scientists in New Hampshire and other places. It's really fantastic. Strong work and a wonderful scientific community family that you've been built there. I wanted to introduce everyone to Dr. Jude Park, who is new faculty in our Rhode Island Hospital COBRE on opioids and overdose, and new faculty to the Brown School of Public Health as well. So excited to hear her present on mitigating the risks associated with illicit fentanyl.
Thanks, Tracy. Can everybody see my full screen?
Yes.
Yes.
Great. All right. So I am going to talk about some of the work that I've been doing actually at Johns Hopkins for the last few years. I'm very excited to be joining the COBRE and Rhode Island Hospital as well as Brown in the fall. So I actually met Tracy as a PhD student back when the fentanyl epidemic hit. And back in 2016, Dr. Susan Sherman and I conducted a survey of people who inject drugs at the Baltimore City Needle Exchange and found that about 20% of people were actually unaware of the presence of fentanyl in the drug supply at that time. And that was, one of the, that was kind of like the beginning of a lot of our fentanyl work here at Johns Hopkins. And it was a tough time too. We lost 12 research participants within the span of a year. We lost a colleague as well. To go back in time even further than that, I actually, if you can hear my accent, was first introduced to the field of epidemiology and public health, as well as harm reduction through the COBRE Institute, working on a hepatitis C study with Dr. Lisa Ma. So that was many years ago, and now I am happy to be presenting some of the harm reduction oriented work that I've been involved in. And I have no conflicts of interest. So I'll be talking very quickly about the fentanyl epidemic and then diving into some of the different interventions that I've been involved in working on, and hopefully there will be time for questions as well. So as Jody mentioned right at the beginning, we are in the midst of an opioid epidemic driven largely by illicitly manufactured fentanyl, and over 93,000 people died in the US from drug overdoses in 2020, which is a 29% increase from 2019. And so I ground a lot of what I do in terms of this framework that I developed with some colleagues called the Continuum of Overdose Risk framework. And so in addition to thinking about the drug use continuum for all the way from drug initiation to fatal overdose, I do like to emphasize the need for a multi-pronged approach to combating and addressing overdose. And harm reduction is kind of the core of what I do, but a lot of these other aspects are very, very important, and we talk about them in the paper. So the strategies that I'll be talking about today include drug checking programs and safe consumption spaces. And please feel free to ask any questions towards the end. So drug checking involves the testing of drug samples to check for the presence of fentanyl and other substances directly in the drug supply to promote awareness and encourage harm reduction behaviors. And it has been a tool that's been used both in public health and community settings, particularly in Europe and Canada, but it has begun picking up in the US as well. And they look different in different settings. There are lab-based programs, there are hybrid models that have a community component and a lab component. The major advantage of drug checking programs over traditional surveillance and toxicology reports is that they provide a way to rapidly inform the community. They don't require the seizure data or reliance on arrests, you also can get the information before an overdose occurs. And so they can be preventative rather than responsive to overdose. So there are a couple of questions that myself and other colleagues have worked on over the past few years. One of them is this question of how accurate are existing drug checking instruments. And Dr. Tracy Green was a co-PI of this study with Dr. Sherman. And we found that fentanyl test strips had high sensitivity and specificity compared to GCMS. We also tested the Bruca Alpha, which is an FTIR instrument. and showed relatively high sensitivity and specificity as well. I mentioned earlier that we did see an awareness gap in the community regarding the presence of fentanyl back in 2016. This is data that's actually currently under review that we collected just before COVID hit. So at the beginning of 2020 in Anne Arundel County, Maryland. And we still see that there is this discordance between whether people report fentanyl use versus actually screen positive for fentanyl. So although this is a pilot study, I think that there is still a lot of room for raising awareness of the local drug supply in communities who use opioids and drugs. Another question that we've looked at has been, can a brief fentanyl test strip-based intervention reduce overdose risk? And from this pilot study called the FIT study, we surveyed women who used opioids in an existing NIH-funded cohort study, and saw that when interviewed at baseline and 1 month later, some reductions in drug use behaviors as well as risk behaviors, including solitary drug use. Most people were interested in using these strips, they used them, and they said they would use them in the future. So it was positive to see that there was this response from the community directly at risk. And I'm going through these quickly, but we also evaluated the uptake of fentanyl test strips in 2 large syringe exchange programs, one located in Baltimore City and one located in Delaware. And again, we saw that the majority of people who were offered fentanyl test strips used the strips. Although the majority of the results that came back were positive, people were, in fact, some people were surprised by the result, and half to 80% engaged in risk reduction behaviors. And so this paper was just published earlier this year. And it's great to see that federal grantees can now use federal funding to purchase fentanyl test strips. This was a major barrier for a number of years. So in the next year, we will see the scale up of these programs. And I'm very excited to help continue to build the evidence base around them. Now, so the drug checking programs are kind of one aspect of the overall drug supply and environment, and really focus on what's happening locally. But we were also interested in what is happening nationally. What are the national trends? And one question that I got asked a lot was, well, is this, are these trends that we see in the overdose data a reflection of mixing of drugs, like actual or polysubstance use, drug contamination? There has been a lot of debate around this. So to test this empirically, we submitted a FOIA and received the NIFLS data set from the Drug Enforcement Agency. And we received data up to 2016. And so, many years have passed since this analysis was conducted. But just to say that there was regional variation in the, and this example, we looked at one example, which was the mixing of fentanyl in cocaine and methamphetamine samples. We did see, if you can see on the map, towards the Northeast, there was an increase from 2014, 15, and 16, particularly in New Hampshire, Connecticut, Ohio, and Massachusetts. And so, yes, it's a rare phenomenon, but this kind of has implications for who are the people who need to be targeted with naloxone and treatment programs. Are people truly aware that they might be using fentanyl? And in that vein, I'd like to conclude with some data on safe consumption spaces. So the current interventions that we have, treatment, drug checking programs, naloxone, syringe exchange. These are all fantastic and very necessary. But the reality is that about 30 to 40% of people report that they are not ready to give up using drugs or stop using drugs or enter treatment. And so what can we do for those people, and particularly those who continue to use fentanyl and are at very high risk of overdose? So an intervention that's been proposed and actually implemented in a number of countries, including Canada, Australia, and Germany, and recently was authorized in Rhode Island as a pilot program, safe consumption spaces, which are also called harm reduction centers or supervised injection facilities or overdose prevention sites. And back in 2017, as part of the forecast study, Dr. Sherman, Green, and myself also looked at willingness to use safe consumption spaces among people who use drugs in Baltimore, Providence, and Boston. And we saw that the majority of people would be interested. This isn't going to work for everyone, but certainly among the high risk community-based sample that we surveyed, this was highly acceptable. And we saw the highest willingness in Boston compared to Providence. And we suspect that this might be due to the active grassroots organizing that occurred back in 2017. So we also in that study looked at reasons why people may not be interested in using a safe consumption space, and concerns about arrest were number one across the board. This kind of points to the continuum of overdose risk framework that I shared earlier, in that a lot of these interventions can't really be implemented in a vacuum. We do need to examine the policies and laws that govern a lot of our response and interactions with people who use illicit drugs. So stay tuned. There is a lot more coming. But just to say that in addition to these ongoing projects, I'm also hoping to start some more harm reduction research, in Providence, and really looking forward to working with the COBRE on that. Thank you for the time, and these are some acknowledgements of funding and collaborators, as well as our participant staff, postdoc students, and institutions.
Fantastic. Thank you so much, Dr. Park, for an amazing overview of the many different mitigating opportunities for fentanyl test strips and safe consumption spaces, and some of the other harm reduction interventions to potentially come. I'm just making sure we may have time for, it's tight, but one question or comment. I'm just looking, let's see. I do actually have a question insofar as many of the interventions we've been are really geared towards people who are using opioids. What are your thoughts about things like fentanyl test strips and even safe consumption spaces for people using stimulants, and especially maybe people who might be smoking crack, for instance, maybe not injecting?
I think it's really vital to engage these populations. The majority of people that we survey in Baltimore, at least, actually use cocaine and fentanyl together. That's been a trend that's been rising. And we've also seen a reduction in the amount of injection drug use. A lot of people are now opting to snort fentanyl just because of the risk of overdose. So given these shifts, I think, and the fact that there is very small amounts of contamination of cocaine with fentanyl, or mixing of cocaine and fentanyl, there may be people out there who, primarily cocaine users who may be exposed. And the same goes for prescription opioid pills that people might buy on the street, benzodiazepines. So I think it's important to be as inclusive as possible.
Great. We're excited to have you in Rhode Island, virtually and physically whenever we can all join together. But welcome. And welcome to the COBRE family and to all of the INBRE family across.
Thank you so much.
All right, our next speaker is Carolina Haas-Kofler, who is coming to us from Brown as well, Brown University. And she is an associate professor and bridges her preclinical and clinical research and has an exciting lab doing phenomenal things. And we're going to hear a little bit more about oxytocin to reduce stress-induced opioid relapse and from her human laboratory study. So I will pass it over to Carolina.
I think she's muted.
Oh, okay. I think Carolina, you might have, there we go.
Good. I have two microphones. Sometimes one doesn't want to work. All right. Oh, do you want me to share my screen?
Oh, please do. Yes.
Right. I'll do it. Number 2. And then, do you see my slides? Nope, you don't. Can you see my slides?
We do.
Yeah, wonderful. All right, thank you very much. So how I end up to be in this line of business. So I am a basic scientist by training. I am a chemist, I'm a pharmacologist. I ended up to do neuroscience, and then now I'm working in the Department of Psychiatry, Human Behavior in the school in the medical school at Brown, and in the Department of Behavioral Social Science in the School of Public Health. So I started to work because I am a stress scientist. I work on stress. I look on stress. And I got interested in the stress is because in addition to my background in science, I was also in the military, and I was deployed 3 times. I was deployed during war conflict in Africa and in ex-Yugoslavia. So I learn and experience in firsthand the issues associated with stress, and particularly on the re-challenging effect of a particular experience that is traumatic or increase the stress level in people. And so the thing that I start to see in population that's been affected by stress disorder very often are comorbidity with substance and alcohol use disorder. And so this is how started the work that I am going to talk with you. So the majority of my work is really trying to reduce the knowledge that we have, this big gap of knowledge between neuroscience, a preclinical model, when we transfer into human laboratory study to eventually go in randomized clinical trial to end up in a clinical settings. So I'm going to start actually my first slides with an epidemiology slides. And the reason why I want to do that is because very often we are looking on those statistics just as a statistic. So if we look at that in the 2020, we have over 92,000 people die for drug overdose in the United States. That's a big number, but that's also it's a big country, the United States. So let's look it up in perspective on how a small little state, in the state of Rhode Island, 396 people die. That means more than 1 person a day die for drug overdose in the state of Rhode Island. That, if we bring into a more clinical perspective, means that the tools that we have to help those individuals are not sufficient. And people that are working in the first line, they have see this kind of failure, and particularly the stressful environment or living in this kind of condition, it is affecting also their line of work. So what does stress in terms of the opioid use disorder? And so it's been seen at this point for decades, and is very knowledgeable that stressful experience can affect the likelihood of remission of drug seeking, reduction of abstinence, continuous drug use, and eventually relapse, which is bring you then to an overdose. So those stressful events are consider any form of stress that can happen in every moment of your life. And there's been seen that there is such a strong association between stressful event and remission for drug use, even for a relatively long period of time scale. So more specifically, this paper that is highlighted at NIDA, the National Institute of Drug Abuse, is that the program that targets stress exposure, stress reactivity, resilience, could be an helpful component for developing a comprehensive approach for helping people in management and prevent relapse. So the fact that stress and opioids are connected to each other because stress has been seen as substance use phenotype. And this is to the fact that very often opioid is being used as a coping strategy. At the same time, the use of opioid dysregulate the stress system, that the most difficult things that happen to individuals with opioid use disorder. And even when they try to stop to use the drug, stress does not halt, continues to be present in their life. So this cycle between stress and opioid, how they interact with each other from a directional point of view, is actually very obvious. And believe it or not, there are no FDA-approved medication for substance use disorder that specifically target the stress system. So we have now a stress system that's so much involved into the process, development, maintenance of those individuals, and there are no medication that's been used that target specifically the stress system. As you well know, that has been mentioned many times during the symposium today, we have only 3 medication available. And those medication, what is called from pharmacological point of view, there are direct pharmacological target, meaning that there are agonists of the mu-opioid receptor, partial agonist or even antagonists, but they all target only the mu-opioid receptor. This is a little bit different for alcohol. With alcohol is a more dirty drug with multiple site of action. So we have different drugs that target different aspects. With the opioid use disorder, we have only one specific pharmacological target. So how we connect this pharmacological target to the stress system, because we see this on a phenotypic level, we see a behavioral level, we see how much stress affect the stress system. And so I will bring you a little bit back into the neurobiology, neuroautonomy to see how stress, opioid use disorder, and the medication that I am proposing is that are connected together. So stress start at after a stress insult. Within the hypothalamus, we have an activation of the corticotropin releasing factor. We have also an activation extrahypothalamic region, like for example, the amygdala, which is the CRF is being secreted into the pituitary. From the pituitary, the adrenocorticotropin will be released in the systemic circulation, reach the adrenal gland that's are located on top of the kidney, release the cortisol, and the key cortisol as a feedback loop is going to inhibit additional production of CRF from the hypothalamus. So this is the cycle of the stress, which start at central level and is connect for peripheral level into a feedback loop that will inhibit again at the level of the CNS. So how all of this will now be connected to the opioid use disorder. These opioid receptors are ubiquitous in every single angle of this pathway. We have at the hypothalamus, we have it in the amygdala, we go all the way to the periphery, until we go to the cortisol from the adrenal gland, they are located all the way through. So since the receptor are distributed through the entire HPA axis, we have a connection now that an overlap of pathway. And then there is the beta endorphin. Beta endorphin, what it does, inhibits itself the CRF production in the hypothalamus, as is an opioid neuropeptide and also a hormone as well. So now we have this compound that's also connected within the stress system. So how we are connecting now the pharmacological intervention about oxytocin. So oxytocin, which is known also to be the anti-stress hormone, has properties that are consistent with the neuroanatomical and neuroendocrine pathway that I just showed you. It has also an exceptional motility through the brain and through the general circulation, exactly like within the HPA axis. So there are those is able to behave both as a neurotransmitter and as a hormone, which are the two chemical messengers that modulate stress response. So what it can do is that we thought that this molecule can help to reestablish the feedback regulation that has been disrupted at the CNS level. Likely enough, oxytocin is an FDA medication that is approved. So we were able to use intranasal oxytocin as a pharmacological entity that can be included within our laboratory studies. The protocol and the paradigms that has been utilized for the human laboratory study came totally from a preclinical model. Actually, this model, I tested this model before in rats before going into humans, and it's exactly, I follow exactly the same paradigms in order to reduce possible translational gap. In terms of the humans, we have individuals that are very typical, those inclusion criteria when you have an intervention, that's a pharmacological intervention. The only thing that I would like to point it out to you is that we are looking for individuals that are current stable on either buprenorphine, naloxone, or methadone for at least 3 months. So we want individuals that are stable on a medication therapy, but also at the same time, they need to score 0 on the withdrawal scale. And the reason is because we are looking specific for a stress induction in people that are stable on medication. So we're not looking at a withdrawal state of the individual, we're looking up on the stress induced component. Regarding the exclusion criteria, again, very straightforward regarding the medication or for a pharmacological intervention. What we need to pay attention is more medication that interact with each other, because we have here individuals that are in opioid replacement therapy. They need to look if there is a drug-drug interaction with the oxytocin and with the yohimbine, which is a pharmacological entity that we use for induced stress. This is the protocol is a typical 2x2 mixed factorial design. I have oxytocin and placebo. This is a between subject factor. And then they go through a within subject factor for laboratory 1 and laboratory 2, where do receive a stress induction or a placebo distress induction. Clearly, this kind of clinical trial is FDA regulated, and it needed an IND in order to administer 2 medication to those individuals. So in terms of the study itself, this is a very is a study that is done by in a very specific manner. We have an administration of the drug. We're waiting that is going to reaching the peak So all the neuroendocrine activation is initiated. Like I mentioned, this was already tested in a preclinical study. And currently I have 3 clinical trials that test in the same protocol. And then we start the opioid cure activity, which is what it does when after start the stress induction, we have the opioid modification in order to really highlight the stress signal with opioids. There is an induction strip, there is drug cue, typical paraphernalia with the drug in a bottle. There is syringe, and then they go through a video where you can imagine those images are very salient, and they go both from pills, crushing the drug, and finally injecting. So what I would like to really just say that being a stress researchers with science, strong basic science background, what I learned from my past career and my experience, that I always keep an eye what's really happened in the world. So that will help me to look it up what happened at clinical level and see what are we facing as a needed and failure. And so when I built a human laboratory study, which is usually conducted just to translate it from finding from preclinical to clinical level, I do in this particular case a reverse translational approach. So I evaluate method for exploring mechanism underlying medication effect, and then I use this one in a fully controlled clinical condition. So this laboratory study is designed to evaluate oxytocin effect on opioid craving as a functional stress. Basically, we test this in integrative pharmacological stress induction paradigm, pilot to acuity procedure in a very controlled environment to really single the effect of stress and using potentially an adjunct therapy. Up to this point, we have no adverse event. What we actually did, we evaluated the salience of different opioid cues. We definitely see that people that were taking drugs were much more affected by the rattling of the pill inside the box. Other people, we noticed that when we do the blood drawn for the clinical assessment, the needle, it really was a big cue for them. Different amendment. But one thing that actually we look it up is that we have to increase the date on the age of those our individual. Usually 65 is a cutoff in clinical trials. We went all the way to 70 years old, just because we have individuals that actually realize that needed continues to have support even during their the senior age. And we use the removal alcohol use disorder and exclusionary criteria because it was just not possible. This is just a console diagram to tell you how we screen how many people up to this point, who were excluded, and with downsize of the COVID-19 pandemic, we stopped and we just resumed. But we have the people that we included were they're all completed, and they're going to be included in the analysis for intention to treat. What I want to notice is that in the exclusion criteria, when they come in the person screening to do a full medical screening, people that were excluded were all for clinical reason. So liver failure, high blood pressure, people who intended suicidality, and concurrent substance use in the past 3 months. So in summary, just to conclude, that I want to tell you is that the pharmacological target that focus on stress exposure and stress reactivity and resilience can be utilized for relapse prevention. And we're trying to do this one in a very, within a clinical trials, in a pharmacological intervention, and do a reverse translation paradigms, learning both from a clinical aspect, what we're facing every day, and look it up on the preclinical model. So we target neuroanatomical and neuroendocrine pathways shared between the stress and opioids. We utilize a pharmacological stress induction paired to acute reactivity in a very controlled setting. And then we test an adjunct therapy that can be included to the FDA approved direct opioid receptor pharmacologies, which is we have in our hand. hopefully that we can provide additional support during the stress period that can happen during any moment of their life. So I want to thank all my lab. I want to thank you particularly Caroline Flight, who is the nurse of the CADRE for this COBRE project, my research assistant, and all my the research team. My active funding, and in specifically within for this particular project for the COBRE project, and the CADRE investigator and the study physician that are involved in this program. So I'm open to any other question if people has it. Thank you.
Wonderful. Thank you so much, Carolina. I think we have time for probably one question at this time, but such strong work. And it's amazing to see I see some of your lab and your colleagues and students there also on the call and on this event. So it's wonderful to have support. Thank you.
Thank you.
I have a question. Actually, I'll just ask one question because I have like 1,000, but this kind of is in part reminiscent of some of the work that Kenzie Preston has done with Epstein over there at NIDA, looking at the role of stress and relapse in particular. So I'm fascinated on that level. Secondly, I'm also equally fascinated by it in the context of the oxytocin. And it parallels some of the work that, we're seeing with ecstasy that produces empathogenic effects. And to some extent, as we talk about oxytocin as being the bonding hormone, a love hormone, and actually even people have gone to look at it in terms of abuse liability, in terms of its direct effects. But I'm wondering, back to the stress issue, has anyone actually tried to, if at all, say use dexamethasone, which blocks the release of ACTH from the pituitary gland, to see if that suppresses such effects regarding, at least preclinically, with regard to reinstating drug-seeking behavior? And if so, would that interface with or enhance the ability of oxytocin to have its effect?
So this is an excellent question, and I can have an entire talk about that. And that has to do with the fact that the limitation then when we study stress at preclinical level is that what we can apply to humans when we go in a human laboratory study is different. So when we look at upper isolation in animals, it's different when we recruit our patient or participants for a particular studies. So the direct pharmacological approach in terms of just blocking the production of eventually cortisol will be not sufficient. So what we really need to create an environment where an individual can experience that particular stress, both from neuroendocrine activation and as well as specific for the naturalistic environment where will be exposed. And in the alcohol field, we have much more experience on that. We were able to recreate a bar lab, for example, in order to create that specific environment where people can live the particular experience. With opioid use disorder is a little bit different because the environment can be everywhere. It can be a car, can be in the parking lot, can be your basement, can be everywhere. So we have a little bit more difficulty with that. So we rely on pharmacological ways on how induce stress. And the reason why I choose the yoimbin, so going back to your question about the dextromethasone, is because he start to activate the neuroendocrine activation from noradrenergic aspect. So we have an alpha-2 blocker. We initiate the process. So the HPA axis has been affected as a secondary manner, which is closer to a flight and fight response.
Great. I'm just going to step right in because this is such a rich discussion and one that I can see we could continue on with for some time and exciting research to continue on with. But thank you very much for the amazing presentation. And we're going to actually move over to our final presentation, a talk from Brendan Jacka, also from Brown. he is an investigator in epidemiology at the Brown School of Public Health, and he is a pilot COBRE grantee. And so he's going to share with us about the impact of responding to opioid overdoses among community members, and that pilot study, some of an early findings. So I will welcome Brendan.
Fantastic. Thank you so much, Tracy. I'm just going to share my screen to get started. And just as a quick introduction to the crowd, I actually worked with Dr. Park in Australia a decade ago at the same institute on that same hepatitis C project, which is, I guess, shows the small size of Rhode Island, where it seems to bring everyone together. And that kind of gives a little lead into the work I've done previously, which is my background was laboratory-based research. So I was interested in hepatitis C, largely how it was transmitted or the connections between people and different viruses. And it led to myself doing a postdoc in Montreal, Canada, where I moved from the laboratory side into more of substance use side of research. And moving to Brown University since then, my work has expanded into the topic that I'm about to talk to today, which is trauma-related work, and then also overdose prevention, while focusing as well on access to health services for people who use drugs. So it's aligns maybe with Dr. Park in the public health realm and touching more on how do we improve access to care and prevent adverse effects of substances. So I would clarify here that I have no formal training in psychology or trauma-related work. So hopefully what I say is accurate. Feel free to raise a hand or leave a message if I mispresent anything. This work has really kind of followed on the back of what was presented before, which is like the rapid increase in overdose deaths in the US. And what I also wanted to point out is that it's building on non-fatal overdoses as well, I think. Understandably, there's a lot of focus on mortality, but this work is trying to examine whether there's, what the impact of non-fatal overdoses is. So moving on, I just wanted to say no disclosures for this research project. And I'm going to try and keep it quite brief. This work is in progress, and so well, I have a few slides to present in terms of results, but the justification for this work is that in the US and Canada as well, as overdose deaths have increased every year, in the US by an extra 10 or 15,000 people each year, the decision has been that the government says, okay, we'll provide naloxone, which is an overdose antidote to all the people in the community, and everyone walking around in the state should be carrying naloxone and ready to act. And it parallels what we said with heart attacks, which is people should know CPR and you should be ready to react to this. So increasingly, we're moving away from professional responders and saying to people in the community, you're around, you're here, we need your help. Additionally, particularly in Rhode Island, and I assume it's similar across the Northeast area, is that a lot of overdose that we know about overdose deaths occur in a private place. So 2/3 or more of deaths occur in someone's home. And so, we can imagine that if people are using drugs at home and they're not really having anyone around, then there's less chance to intercept in that overdose event. Compared to other places, central places such as New York or Montreal or San Francisco, where a lot of people are kind of centrally located, and there may be opportunities for other people who use drugs to intercede. So this is the kind of a quick rationale why we think that responding to overdoses may be a concern, relationship to trauma disorders. So if we look in the literature, we know that people that respond to natural disasters are affected by trauma and PTSD. We know that professional first responders, firefighters, EMS, and police are affected. And we also know that taking a step back and probably a more chronic exposure is this burnout and compassion fatigue that's been experienced across the board, across social work, community health workers, emergency services. People are essentially sick of the negative impact, understandably, and COVID's only exacerbated this. The issue with overdose responding in the community is that we know so little about what's happening to those people that are newly tasked with responding. So people in the community, we might call them layperson or citizen opioid overdose responders. And so that's what the goal of this study is to look into, really, can we identify these people in the community? A two-step process of, can we find and recruit these people in the community? And then once we do that, can we characterize their PTSD symptoms, and in time look at individual or overdose event-related correlates of PTSD. The reason why we're interested in AIM-1 is that often, well, with the stigmatized nature of substance use, people who respond may be harder to reach. And I say that in terms of hardly reached, and more of a criticism on the research community and service providers in terms of the people are out there because they are responding, and it's our responsibility to meet them where they are and then demonstrate to these individuals that the work we're doing is relevant to them. So we took some previous work, which has recruited people who use drugs, and we're expanding that to meet other people who have responded, such as family members of people who use drugs, people in recovery, or are just general community members who have responded. So the first step is to demonstrate that our team has that capacity. And then, as I mentioned, the second is, once we have these individuals, how does PTSD affect them? So we're recruiting people over the age of 18 who can speak English, who are not professional first responders, and who responded to an overdose event ever in their life, but their worst event can't be in the last 2 months. So if their worst event was in the last 2 months, then we ask them if they responded to another event, and that would be the index case. So the case where we try to detect PTSD symptoms related specifically to the overdose event. Just quickly to show you that we have questions related to the participants' demographics, the trauma exposure. For folks that say that an event other than an overdose was the most distressing, they also answer another tool about that event, but all individuals will answer the clinical assessment for PTSD based on their worst overdose incident. So we will be able to say, is there a connection between overdose responding and PTSD symptoms? We also looked at some other validated instruments. We have some simple statistics. We just show you what we've got from our first 43 out of 100 participants. So there's nothing, there'll be no analytics here. I quickly wanted to demonstrate that we have a reasonable distribution of adults, people about 33 years old, half female, but we do have a larger group of transgender participants. About half of participants are white and about 10% Latinx. We also have quite a high proportion of people who are unhoused in the last 12 months, but a reasonable proportion that are uninsured. Sorry. Completion of high school was high in this population, but only about half of people were employed, and then about another 20% were not seeking work, so were retired or students. So what we feel like is we're reflecting a large population in this study. I just quickly wanted to point on the trauma exposure of these individuals. So we ask, have people been exposed to numerous incidents? This is a very standard questionnaire. And we asked if that it's happened to themselves, or they saw it happen, or it happened to someone and they heard about it. And we really wanted to highlight that the people that are being recruited in this study are exposed to really like a very large number of traumatic events in their life, about 10 per person, 10 different events. So we just wanted to kind of highlight the complex trauma that may be occurring in this population. For the overdose incident themselves, I said that we know that most overdose events happen at home. In this study, again, 2/3 happening in a private place. 3 out of 4 said they had a close relationship with the person who experienced the overdose. And about half of the participants also used drugs at the same time. The response pretty evenly across the board was a mix between calling for 911, administering naloxone, or doing rescue breaths, so CPR. People were often transferred to hospital, about 2 out of 3, and EMS most often attended these. In the 6 months after an overdose event, people said that they decreased, about equal proportions decreased or stayed the same, and very few people increased their substance use in the 6 months after the overdose response. The crux of the main outcomes from this work is really looking at clinical PTSD through the CAPS-5 score. In our study, about 2/3 of participants would be diagnosed with PTSD. The folks that identified the overdose event as most distressing were more likely to have PTSD. In fact, all of the people that had PTSD were in the closely related group. So of the 25% of people that said they weren't closely related, none of them had PTSD. There was also high co-occurrence of anxiety and depression in this group. So about 70% of people with PTSD also had anxiety and depression, which we might not be surprised about. Just wanting to be cautious of time. So the work here is demonstrating that so far we're able to recruit for 40 or 50 out of 100 of our participants. So we know individuals in the community and we're able to access them. We're able to have them on the phone and give them the interview. As I said, the reason why we're focusing on this is to say this is a hardly reached group that really will need our support. So we need to demonstrate sustainable ways to access this community. Similarly, the responses that people are doing during an overdose are diverse. So it's not just all in home, it's not just all one type of response. So there's potentially touch points that we can work on as we develop interventions, either as prevention or post-overdose interventions. And finally, there's substantial burden of PTSD in this population. With other stressors, we might expect maybe 10 to 20% of people have PTSD symptoms. So there's clearly a need for further research in this population, in which we hope to take on in future studies using this COBRE funded pilot as preliminary data. I just wanted to acknowledge our funders through the COBRE and Opioids and Overdose and our GMS, also colleagues at Brown University and the University of Rhode Island, and community partners who have helped us with our recruitment. And that is the end.
Thank you so much, Brendan. I think we are closing to the end of our time, but we have time for a question from our group here.
Apologies for the hurry at the end. My timer went off.
Maybe a reflection too. It's strong work and amazing to be doing that in the midst of a pandemic. It's not just a hard to reach population, but it's a hard to reach population at a time when we it's hard to do research, period, with human subjects in the community. So bravo.
Thank you. We have found that one thing that I would point out to anyone else looking to do remote research is Some of our tweets and Facebook posts ended up being picked up in places outside the US with other people looking to do the survey. So finding ways to confirm people's identity is helpful, but it's also difficult because that may discourage other people from participating. So we're happy to chat if anyone has questions.
Quick follow-up question. Great presentation again. Impressive to reach that population. I was wondering if you had data on their treatment engagement for PTSD in particular, or whether there was interest in engaging in PTSD treatment in that population.
Yeah, I think that's a fantastic question, and it's not something that we've captured in this data set. We've looked at a few other more kind of psychology predictors we didn't have a chance to put in, kind of access to healthcare. But we are considering a next step intervention to see kind of whether the intervention we provide would need to be significantly different to other people with PTSD. But it's a great question. Thank you.
Great. Well, we are coming to the end of the hour, and really appreciate everybody hanging in there. We have a treat at the end. Steve Higgins is going to wrap it up and give us some, tease us with some exciting information.
Great. Thanks, Jody.
Thank you all.
Yeah. So let me see if I can share my slides here. Are people seeing those?
Yep.
Yes.
Great, great. So it's really a pleasure to have been part of this, and I want to express my gratitude to each of the speakers who were outstanding, and then also to my co-chair, Dr. Rich, and also Dr. Green, who has really helped us out keeping the symposium going, and then the NERIC program organizers and support staff who have been terrific. So then I'm gonna, if I move my slides, I have, oh, here we go. So I want to close by, well, I should mention that I have no conflicts of interest to disclose, and the work that I'm going to share with you now is supported by NIGMS, the COBRE grant at the University of Vermont, where I direct the Vermont Center on Behavior and Health, and also by a NIDA T32 grant. So I'm going to talk about psychomotor stimulant use and the increasing levels among people who have opioid use disorder, because it's a big contributor to these increasing rates of overdose that concern us all, and what some people are referring to as the twin epidemics now. The opioid crisis has been going on for several decades, and then this uptick in cocaine and methamphetamine use. And as has already been mentioned, and you all know, the medications that are so wonderful in treating opioid use disorder do not treat psychomotor stimulant use disorder. And we don't have any effective medications specifically for psychomotor stimulants after more than 30 years of research. So I wouldn't hold my breath, we'll get one soon. So the question is turned to, what about psychosocial interventions? And that's what I want to talk about here. There's really just one. So we've been looking at those. I'm having some trouble advancing these slides, but bear with me.
Put it on full screen, and then you'll be able to advance.
Oh, that's the problem. Thank you. Thank you. So let me scroll through this. I thought I was on full screen. All right. So that's the questions being asked. And there's really only one intervention. It's contingency management. And so I want to draw your attention to a review paper that my colleagues and I, including Eli Klemper, who's been a participant in a symposium, have just published, looking at contingency management, specifically in people who are in treatment for receiving medication medication treatment for opioid use disorder. And it just came out in JAMA Psychiatry, and I thought many of you may not have seen it. And it also has a podcast associated with it. You can access these on the JAMA Psych website. All right, so we conducted a systematic search, primarily getting most of our articles through PubMed, but to be thorough, Cochrane Central, Web of Science, and reference sections of published reports. And we went out from inception all the way through May of 2020. And we were interested in prospective experimental studies of any kind of monetary-based CM. It's often vouchers, prizes, or it could be cash in some instances. Again, the participants had to be undergoing medication treatment for opioid use disorder. So we identified 74 studies or 10,000 participants, more than 10,000, who met inclusion criteria for the systematic review, and then 60 of them, which involved 7,000 participants, had enough data in the study that we could include them in the meta-analysis. We were going to use Cohen's D to look at effect sizes. And we followed all the guidelines. These reviews have really become very formalized. And so we did PRISMA guidelines. We had independent investigators extract data and resolve any discrepancies. And so the primary outcomes we were interested was the effect of CM at the end of the CM intervention on common clinical problems. I'm going to show you data on psychomotor stimulant use, but we also looked at polydrug use, illicit opioid use, smoking, cigarette smoking, therapy attendance, and medication adherence. What we deemed to be 6 central problems in this population. And the use of psychomotor stimulants, we think, undermines and contributes to all these problems and risks undermining the progress we made in mitigating the opioid crisis. And that's pretty scary. All right, so I'm going to show you here a forest plot on our findings for the efficacy of CM in treating psychomotor stimulant use. Of course, it's either cocaine or it's methamphetamine. And the way to read these forest plots is this center line right here in the middle. If the point estimate is to the right of that, then it favors CM. If it's to the left, it favors the control treatment. As you can see, of the 18 studies that contributed data for this meta-analysis, not a single one is on the left side of that zero line. And then on the right side, if the confidence intervals don't overlap with the zero, then you have a statistically significant effect. And the way we organize this forest plot is we go from the smallest effect size at the top to largest effect size at the bottom. And then the final row is the meta effect size. And so you can see there's overwhelming evidence supporting the efficacy of CM for psychomotor stimulant use. And it's especially important to think about, or when you're looking at this data, to keep in mind that it's the only treatment that's been shown in controlled trials to work for psychomotor stimulants over 30 years of trying essentially every medication, psychosocial treatment we could think of. And so because these Cohen Ds are often hard to interpret, the Cohen's D is a 0.70 here. And so a quick way of kind of like of understanding the practical implications of a 0.70 Cohen's D, that would translate into 76% of the people who received CM had a better outcome than the average outcome of the control treatments. So again, overwhelming support for efficacy. So yeah, so that's my first bullet there and wrapping up. And I mentioned at the outset here that CM's efficacy I only showed you for psychomotor stimulants, but it extended across each of the 6 outcomes that we looked at. And so what I want to leave with you is the importance that we should follow the evidence and promote greater integration of CM with mode. And we need to increase accessibility as is recommended now in the Biden and Harris year 1 newly released drug policy priorities. I don't know if you've seen those, but they're out, and CM is right among the top. And it's well supported by the scientific evidence. And the reason it's important for me to bring this to your attention is you in most states, you cannot get reimbursed for using contingency management. So we have this terrible crisis of overdose that we spent several hours talking about in many different directions. We have one intervention that can get at a major contributor, psychomotor stimulant use. And at this point, it's not available in most states in the US. And so we need to advocate that we, the critical point that Jody opened up with, we need to use evidence-based treatments if we're going to get on top of the opioid crisis and now the twin epidemics and stay on top of them. So yeah, so that's what I have to offer. I'll field any questions that you might have and we'll go from there.
Hey, Steve. Can you hear me?
I can.
Oh, I'm fascinated by contingency management. I've been for the longest time. It's one of the first things that I thought was probably more important than Q exposure therapy. Of course, you've heard me say you've heard me advocating the integration of both. But I'm wondering how long. So that graph that you showed, that showed the meta-analysis, I noticed RI-INBRE's work and Ken's and Kenzie's and so forth. How long is that? So they're abstinent, but how long after? Is it just when they're in the program, or what happens when they're
right?
You know, what's the end goal? Is that to get them off of the contingency management, and then what happens when the pandemic hits and they don't have these skills to engage in? You know, that's my only question.
No, it's a great question. And so actually attending to longer term outcomes is a weakness of this literature. There's not been enough attention, and the few studies that did showed no statistically significant maintenance of the effect. But I want you to keep in mind that that's true for the medications too.
Yes, it is.
In this population, we've learned that you need maintenance intervention. These aren't quick fix problems. And so I think we need to integrate CM into medication treatment for opioid use disorder and anticipate that we need long-term maintenance kind of interventions. I see no reason to think we don't, but there's also room for researching novel ways that we might be able to extend the efficacy of CM beyond the period where the incentives are discontinued, but we don't have that that available right now. It's actually the intervention that that Lisa kicked off with, the CM plus CRA, which I have to say, I led the studies. They were out of our clinic. That's the only study, that's the only combination where you can discontinue the incentives with people who have psychomotor stimulant use disorder and sustain the outcome. So we could use the treatment that Lisa outline, the digital treatment. We could try and use in-person CRA plus CM, which is what we did the initial studies using. But I think to disseminate it widely, we should just focus on getting, in the short term, getting CM into as many medication clinics for opioid use disorder as we can. And it's CMS that we need to move off the dime, both at the national level and at the state levels. And so I think Jody probably has much more experience with this than I do, but we need to be the advocates because these populations really don't have strong advocates in their neighborhoods. Jody, maybe you can comment on that.
Yeah, I haven't gotten too much of CMS off the dime lately, but I think you're absolutely right. We need to advocate for this, and we need to speak up for this population. And
yeah,
so
I mean, it's the crisis with the psychomotor stimulants contributing to overdose that my colleagues and I to do the review. And we participated in a number of the trials, so we knew that there would likely to be pretty good evidence, but we didn't realize it would be this overwhelming. And we're hoping that by getting it into a a high impact journal like JAMA Psychiatry, you only get in there if you've really dotted all your I's and crossed your T's. And we didn't know also that Biden and Harris were going to be emphasizing dissemination in their priorities, their drug use priorities, drug use suppression priorities. So anyhow, that's where we're at. I hope all of us that are interested in reducing the overdose crisis, if you see an opportunity to advocate to get this into your community clinics, I think it would be a good thing to do, and it'd be a very evidence-based thing to do. And like I said at this outset, I have no conflict of interest, so I'm only pushing it based on the evidence.
I would point out that, you know, in adversity, there's opportunity, and we got one heck of an adversity here.
Yeah.
In public health, we talk about not letting a crisis go to waste, and so I think we've just kind of been all shook up like a snow globe, and we're all just the snow is settling, and we're seeing what's there. Well, what's there is we had a 30% jump in overdose deaths, and the problem is not going away. And so I think that's great that Biden and Harris are diving in, and we're going to double down on a lot of effective treatments.
Yeah.
And really pull away. I mean, the fundamental problem here is that we don't treat addiction the way we treat every other disease.
Exactly.
Because those people are somehow seen as less than and less deserving, and that really comes from 40 years of rhetoric about the evils and the sort of judgment around the war on drugs. And we have a wonderful example in Portugal where they said, no. 20 years ago, we said, no, we're not treating this as a war. We're not treating this as a crime. We're treating it as a disease. We're taking it out of the Ministry of Justice, and we're going to move it into the Ministry of Health. And the Ministry of Health is going to figure out how to deal with this. And they've done it. And when you walk around in Portugal today, people don't talk about addiction as a crime, as people with addiction being bad people or dirty people or something to be ashamed of. You find out your kid has an addiction problem, your neighbors are, how's he doing? Is he getting the treatment that he needs? You don't see that here. You don't even talk to you don't even mention it to your neighbors.
Yeah.
So that's.
I agree with you completely, Jay. I think we've made significant headway with medications for opioid use disorder during this crisis. It took us 2 decades, but we've made it. I wish it would have been a lot sooner. It would have saved lives. I want to compliment you on your comment earlier about the impact of an overdose on so many people. I never heard it quite put that way, but I have witnessed and been close to people who overdosed, and it's exactly what you just what you laid out. And it's a very moving and important way to think about it, because it does not go away quickly. It lingers for decades among, exactly what you outlined, the family, the neighbors, the friends, the schoolhood friends, the adult friends. It's a terrible thing. And so I'm a little incensed, and I was driven to do this review by being a little incensed. I have a tobacco center, and But to watch these overdoses and to know psychomotor stimulants are involved, and for us to not be using the only evidence-based treatment we have is just really unacceptable. So I think we all need to push back against that.
Yeah. Thanks so much for that important contribution.
Yeah.
Thank you, everybody, for staying so long.